This is part 2 of pancreatitis and exocrine pancreatic tumors by Dr. Hisham El-Akkad, Professor of General Surgery, Ain Shams Medical School. This slide is to remind you with the ILOs of this lecture. This slide demonstrates the epidemiology of pancreatic cancer. Adenocarcinoma comprises the majority of pancreatic tumors. A mucinous cyst of the pancreas might well be malignant, while a serous cyst is rarely malignant. Most of the pancreatic adenocarcinoma occur at the head of the pancreas, and so is the close association with jaundice. When occurring in the untinate process, jaundice does not occur until the tumor reaches up to the CBD. Usually the patient dies before this happens from metastasis or complications. Late presentations include pain, which denotes infiltration of retroperitoneum. Thrombophlebitis migrans is a sign of hidden malignancy, especially when occurring in patients over the age of 50 years. Although not specific to pancreatic cancer, it is one of its common causes and should be looked for. Infiltration of the splenic vein causes thrombosis with splenic congestion and splenomegaly. A tumor obstructing the duct might present by pancreatitis. So with idiopathic acute pancreatitis and a solid focal lesion of the pancreas with pancreatic duct obstruction by CT, MRI, and MRCP, carcinoma should be suspected and tumor marker CA19-9 requested. Pain signals are conveyed through the celiac autonomic plexus and hence the procedure of celiac block for palliation. Patients with tumors bigger than 5 cm do not benefit from curative surgery as these tumors are locally advanced and usually have already metastasized to the liver and regional lymph nodes. Hepatomegaly may occur due to metastasis. Duodenal obstruction mandates a palliative procedure like a gastrojejunostomy unless the patient is already dying. If the procedure is combined with cholecystojejunostomy, another anastomosis between the two limbs of the jejunal loop is added, the anterior enterostomy, and hence the name of triple bypass. CA19-9 is 90% sensitive but 70% specific. Higher levels occur with bigger tumors. Triphasic CT is the main radiology modality. It demonstrates the mass and its vascular pattern, demonstrates local invasion, lymph nodal spread, and liver metastasis. The size of the tumor is measured and invasion of the portal vein assessed. When the invasion of the portal vein is doubtful, CT angiography must be done. Endoscopic, transduodenal, or transgastric ultrasonography is the best to detect small tumors less than 2 cm and the adjacent lymph nodes. A fine needle cytology can also be taken endoscopically under endoscopic ultrasound guidance. Abdominal ultrasonography is inferior to CT in diagnosing and assessing pancreatic tumors, but is useful for detecting liver metastases which might be isodense in CT. Also, malignant ascites and CBD dilatation are well diagnosed by ultrasonography. Positron emission tomogram is useful to screen for occult metastases before curative surgery. Also, it is useful to differentiate neoplastic from non-neoplastic focal lesions like focal chronic pancreatitis. ERCP is useful in palliation of metallic, expendable, permanent CBD stents to relieve the obstruction and palliate patients who are not candidate for curative surgery. Also, ERCP is useful in preoperative diagnosis in patients with periampullary tumors where sphincterotomy is done and the ampullary tumor biopsied. There is no generalized agreement that a histopathologic confirmation should be obtained before initiation of treatment for pancreatic cancer, including curative surgery. If histopathology confirmation is desired, biopsy could be taken with CT or ultrasound guidance. Laparoscopy is mainly used for staging in patients to undergo curative pancreaticoduodenectomy. In presence of peritoneal nodules or liver metastases, laparotomy is abandoned except for a triple bypass palliative procedure. Pancreaticoduodenectomy is the only hope for cure. Unfortunately, pancreatic carcinoma usually presents late, and only 10% do not have criteria of inoperability by the time diagnosis is made. Pancreaticoduodenectomy is an ultra-major operation, and operative mortality correlates with comorbidities. Careful selection of patients who might benefit from the procedure is crucial. Patients with periampullary tumors and those with smaller tumors than 2 cm have the best chances for cure. Unfortunately, this subset of patients is small. As most patients are to be offered palliation only, it is important to target 3 objectives. The relief of jaundice is achieved best by an endoscopically placed CBD stent. If ERCP stenting fails, internal stenting could be achieved from above through PTC. External PTC drainage is the last resort if internal stents could not be deployed or were blocked. For patients with duodenal obstruction, a triple bypass is needed. Such patients do not need ERCP stenting as surgical bypass bile drainage is done with the duodenal bypass procedure. If a stent was already placed, a gastrojejunostomy is all to be done. Narcotics are usually the only effective in palliating the severe pain associated with the terminal illness. Pain relief should not be withheld because of addiction concern. Percutaneous celiac plexus block is a good alternative to control pain, but is effective for only 2 to 3 months. Usually, this is all the time such a patient needs, but the procedure could be repeated if the patient outlives this period. Pancreaticoduodenectomy, well known as Whipple's operation or procedure, is an operation done for pancreatic head and periampullary tumors. There have been many modifications of the procedure. The operation comprises removal of the duodenum and pancreatic head. The resection extends from the gastric antrum down to the first few centimeters of the jejunum. The lower part of the common bile duct below its supraduodenal part is also removed with the specimen. In absence of distant spread to lymph nodes or liver metastases, the most limiting factor for resection is the invasion of the superior mesenteric and portal veins. Some centers would include the infiltrated part of the vein in the resection and bridge the gap with a venous graft. Most surgeons consider the portal vein infiltration a sign of inoperability. The stump of the body of pancreas is then anastomosed to the jejunum or stomach. The stump of the CBD and the stomach are also anastomosed to the jejunum. Carcinoma of the body and tail, when operable, are managed by distal pancreatectomy. Total pancreatectomy is done for tumor cells spreading to most of pancreatic tissue, and sometimes to avoid the troublesome pancreatic anastomosis during Whipple's procedure. Prognosis of pancreatic cancer is poor. Curative surgery improves the average survival from 6 months to 2 years. 5-year survival of periampullary tumors managed by surgery in absence of lymph node spread is 40%, but the overall survival of patients undergoing surgery is only 10% at 5 years. Thank you, and please be ready with your questions in the face-to-face session.